the difference in nutshell how to differentiate the alcoholic chronic pancreatitis versus tropical chronic pancreatitis. I'm not going in details of it, it's widely available in the literature and theory books. There's a very important thing that is also very confusing many times with HCPT with the type 2 diabetes, because many of the symptoms or the signs can be present in HCPT. Also, like positive family history in HCPT present in almost 50% of the patients. The signs of insulin resistance like skin tags or acanthosis nigricans can be present in 7.3 to 4.8% respectively. Even the osmolar symptoms can be present in almost 42.7%. It's very much confusing for the type 1 diabetes as differential. The patient can have the pancreatic calculi in almost 100% of the patients that's too much diagnostic for this HCPT. This is another, the young lady was actually presented with the dysmorphism and the severe acanthosis nigricans, what we can see in the underarms. But I think these are the cases has already been discussed by Dr. Shunitra, because this is the case of Rapson-Mendel syndrome, where we can get the high insulin resistance. So this is the spectrum of the insulin resistance, the residual insulin receptor function from 0 to 50%, where Down syndrome, Rapson-Mendel syndrome, and type A insulin resistance is the majority. So it's the presence with the linear growth retardation, soft tissue growth, hyperandrogenism, particularly the hirsutism and amenorrhea, insulin resistance, diabetes mellitus, and impaired development of skeletal muscle or adipose tissue. So mostly they are thin. Coming to the lady, actually presented a few years back in our OPD at Arindam Medical College. As a 15 years of the lady is presented with new onset of diabetes, along with the patient have oligomenorrhea, mild hirsutism, hypertension, and paroxysmal myopathy, and there is no family history of diabetes. You can see the puffy face of the patient. And this is the imaging that shows there is the adrenal lesion. This is the history of adrenal tumor. So it's a case of Cushing syndrome. So in the young diabetes, so we have to find out if there is a clinical suspicion that endocrine-related diabetes causes like Cushing syndrome. That's very important. And definitely here, if we get a patient of suspected Cushing syndrome, we have to first rule out the exogenous Cushing, that is the improper administration of high-dose corticosteroid for long duration, because this is very common in our population, particularly in the rural practice for different reasons. So first, rule out the exogenous Cushing by doing the morning cortisol level, and then we can proceed if there is normal morning cortisol or higher side of the morning cortisol, we can proceed for endogenous Cushing, that by doing 1 milligram overnight exercise saturation testing followed by the confirmatory tests. This is another patient who is 26 years with new onset diabetes. There is family history A negative, and we can see the clinical features of the dental malocclusion. The patient has macroglossia, and patient has skin tags. And this is the imaging, pituitary imaging shows there is a pituitary adenoma, macroadenoma, and patient have clinically acromegaly. So this is another very important cause of endocrine cause of diabetes in young. So apart from the Cushing syndrome, if there is a patient have the very deteriorating course of the diabetes, hypertension, skin tag, and the acral enlargement, headache, and the sweating, obstructive sleep apnea, severe joint pain. So these are all the indicators that patient can have somatostatinoma. So these are the rarer causes, but definitely we have to at least understand as per the Dr. Shunitra's talk. So the obesity in childhood, where we can have the diabetes as a part of the total syndrome process. So this is a 14-year-old boy, the painful menstruation, developmental delay, early onset hyperphagia and hypogonadism. And this has been a case report from Arindam Medical College by Dr. Krishna Shankarji. It's a case of Prader-Willi syndrome. I'm not discussing it because already we have discussed this in Dr. Mondo's talk. Again, this is a Prader-Willi syndrome, which is another child with obesity with diabetes and hypogonadism. So this is the diabetes and okay. Just I will take maybe 2 or 3 minutes. Actually, this is very important part of the talk. So retinitis pigmentosa. So we have to find out whether there is a child with obesity and there is no obesity, and according to that, we can categorize part strong, conshare, and Digmont syndrome. So histochecking is very important, starting from age of onset, temporal presentation, pain abdomen, weight gain, oligomenorrhea, hirsutism, deafness, myopathy. So all we have to at least consider for the history part of the young diabetes. The family history is very important, though type 2 diabetes in 80%, you can get type 1 diabetes in 2 to 4% family history, more than 90%, and maternal inheritance is also very important. And this is the maternal inheritance where you can get the maternal inherited diabetes and deafness. Apart is a mitochondrial the disease transmission. Again, the acanthosis, lipodystrophy, myopathy, hypercortisolism is important. In examination, the fundus, we have to go for retinitis pigmentosa and optic atrophy. The important thing in investigation for triglyceride, low HDL that goes in favor of type 2 diabetes, whereas the SGOT, SPL liver function test, test abdomen, and USG, we can get as part of the treatment. The C-peptide assessment is very important, which can be done the basal or stimulated value, and antibodies for type 1 diabetes and genomic sequencing are also very important for overweight diabetes in young and the moderns. Now, for C-peptide, there are different cutoffs for the C-peptide. For fasting C-peptide, usually less than 0.3, and stimulated C-peptide of less than 0.3 is very important for type 1 diabetes as insulin deficiency. There are different cutoffs of C-peptide assessment, but this is the standard C-peptide. The labels we can consider as for insulin deficiency. Though a study from NS Medical College by management, Srinatha, shows that the C-peptide assessment after the glucose stimulation with 75 gram oral glucose is a very easy technique for assessment of the postprandial C-peptide level, which is instead to do with the meal test, which is a very complex process, so we can't do in routine practice. So this is in a nutshell how to proceed for diabetes in young. So we have to at least give the stress for the family history, then whether the 3 generation present or not, whether ketonuria present or not, then we can go for the simple imaging techniques and other issues with the C-peptide level for proper assessment in diabetes. So with this, I give special thanks to the Department of Endocrinology, Nurse and Sage, Dr. Nilanjan Sharputta sir and Dr. Shami Bhushan sir, my teachers, my patients. Thank you for the patience.